which is the best tool to examine a patient in a shock. And I know when we treat a patient of shock, we know that his shock is a very life-threatening kind of a condition which has got high mortality, maybe shock of any kind. It may be a cardiac shock, septic shock, or any other shock. If we actually don't treat it in early stages, patient might die. So it's a medical emergency, and we should not leave the patient in a shock state, just giving some orders. And it is very obvious that if we treat shock in early stages, it is reversible and we can definitely save life. But it is important at the same time that we need to actually identify shock very early stages. So once that identification is not done in early stages, actually we may lose very important time. And time is a tissue in a state of shock. And day before yesterday, when Dr. Parag was talking of shock, he said ki we should smell shock that in patient is actually having shock. So we can actually smell it very early and start resuscitating the patient. So delay in diagnosis and or timely initiation of treatment can lead to irreversible changes, which actually leads to tissue organ failure and multiple organ failure and death. And special diagnostic and treatment strategies are essential to save life. As we all know that there are different kinds or different etiologies of shock. Very commonly, we know that there is a hypovolemic shock where there is a loss of fluids like vomiting, loose motion, or a patient of trauma or post patient, there is a hemorrhage which can lead to hypovolemic shock. Another kind of shock is a cardiogenic shock, and we know that it's quite a deadly shock where patient of acute myocardial infarction can develop a cardiogenic shock. Then obstructive kind of shock where we know that like condition like pneumothorax or pulmonary embolism can lead to obstruction to the flow and will cause shock. And another very important category, which is very commonly encountered in a critical ill patient, is a septic shock or a distributive kind of shock. But friends, remember, in a patient who is in ICU has actually multiple issues, like a patient of myocardial infarction, poor LV may land up in a septic shock. So sometimes it can be a mixed kind of a shock, or a patient of pancreatitis may develop a hypovolemic or cardiogenic shock. So it's not very clear conditions when we deal with a ICU patient where it is a multiple things are combined in a single patient and we have to really use our skill and knowledge to manage these patients. So when actually we discuss about the pathophysiology of shock, we should understand the subcategories or phenomenon behind the shock. So when there is a obstruction to the flow like this, you get an obstructive shock like in embolism or pneumothorax. When there is pump failure in a body, it is a heart which is a pump. And if it is having a problem, then we get a cardiogenic shock like I told you in a acute infarct case. Then another is if your tank is not filled properly, then there will be no output. So tank has to be filled up properly. So if tank is not filled because of the loss of volume or hemorrhage, you get a hypovolemic shock. And if your pipe has a problem, like pipe is more dilated or pipe is leaky, like in septic shock, capillary leak, you get a distributive kind of shock. So this is just to understand basics of shock. And when you suspect the shock, so suspicion of shock is very common at bedside. You may get a hypotension, which is a very, very hallmark of having a shock. Tachycardia, decreased urine output, abnormal mental status. Tachypnea is a very common finding in the shock patients. Then pooled, clammy, and cyanotic skin. Sometimes you get metabolic acidosis and hyperlactatemia or objective markers of shock. So if you see, these all clinical features of shock are neither sensitive or nor very specific to diagnose shock. So hypotension, tachycardia can occur in multiple conditions, even patient not in a shock. So you have to remember that clinical signs sometimes may not be very, very specific for diagnosing shock. But at the same time, I just wanted to insist and clear that clinical examination is not replaced by any of the modern technology. So looking at the patient, looking at the extremities, pulse, volume, and looking at the mental condition is very, very important at bedside. And within minutes, you can see that patient is not doing well or patient is in shock. So always whenever I go to the patient, I just wash my hand and touch the extremities. Even if blood pressure on the monitor is something like 170, but extremities are cold, pulse is feeble, I actually just ask sister to start treatment because touching the patient is very, very important. And I think it's a very simple kind of a tool which we can use at bedside. And to diagnose shock, we have got three windows. One is a window of a neurological state, that is altered mental condition. Then arterial hypotension, that I told you. And third is a urine output. So kidney, if shows a decrease in the output, patient probably in the shock. And of course, if there is a cold and moderate skin and increased lactate, we are dealing with a shock. So this is a clinical kind of a examination which helps us in diagnosing shock. And remember you, a capillary refill time, which is a very, very important bedside tool. If it is more than 3 seconds, it is a very important and very, very good marker of diagnosing shock at bedside. But always there is a bedside means it's a judgment, it is a subjectivity, and we may lose some patients because of we are not clearly understood the clinical signs. So to diagnose shock, we have a clinical examination, then lot of hemodynamic monitoring tools, and lastly we have got echo and ultrasonography to use at bedside for diagnosing shock. So out of this, which is the best tool to use in a patient of shock or hypotension? And that is my topic today. And I just wanted to tell you what is the importance of echocardiography and ultrasound in diagnosing shock. So as you all know that we put a central line, arterial line. Sometimes I think a lot of anesthesiologists who are working in a cardiac theater are using Swan Ganz catheter or something like EV1000 kind of a minimally invasive cardiac monitor we have. And we use these tools in some patients to identify the type of shock, pathophysiology of shock, and monitoring the progress of shock. And now we have echo and ultrasound, and whether this tool is really, really important tool or not, whether it's a evidence to say that this is also a good tool to examine a patient of shock. So focused cardiac ultrasound has emerged one of the powerful tool for clinicians to answer simple questions to guide and diagnose the shock and to guide the subsequent management in hypotensive patient. And another modality is point of care ultrasound. If you use point of care ultrasound, it is found that it improves the diagnostic accuracy from 60% to almost 85% in those patients of shock. So this really a very good modality. This point of care ultrasound is actually an invaluable clinical tool, not only to make a diagnosis, to rule out potentially fatal conditions, and to provide guidance to life-threatening procedures. So we put central lines or arterial lines. Sometimes even intubation can be done with the use of difficult intubation can be done with the use of ultrasound. So it's not only valuable tool for diagnosis, it is useful in immediately diagnosing some potential conditions at bedside, and we can just treat immediately, like case of pulmonary embolism. We can see RA-RU dilated in a proper clinical setting, and we can start treatment even if patient is not able to shift it for CT pulmonary angiography. So now it is considered as one of the core emergency ultrasound applications. So American College of Emergency Physicians and International Federation of Emergency Medicine has actually made it very clear that it is a core emergency application that everybody who is working in emergency department should adopt this technology and should get trained in this technology. So I was talking about the immediate diagnosis, like this patient has got a massive pericardial effusion and patient is in shock. So large pericardial effusion is seen with the diastolic collapse of the RV. And if you put a needle and you drain the tamponade, patient might be saved at bedside. So this is an immediate diagnosis which is possible with the 2D echo. This is again a huge RV. It's a apical 4-chamber image. And if you see, this is a case of pulmonary embolism, and immediately you can treat patient even in emergency department or in an intensive care unit without further going for CT pulmonary angiography in critically ill situation. So this is the beauty of this modality, that it can immediately give us a diagnosis and we can treat the patient. So far, we actually learned that pulmonary artery catheter is one of the most ideal tool to diagnose the type of shock and to monitor the patient of shock and to treat the patient more objectively in ICUs or in theaters. This is a review published in 2005 in JAMA, and they actually assess the impact of pulmonary artery catheter in critically ill patients. This is a meta-analysis with randomized controlled trials, and what they concluded in critically ill patient, use of pulmonary artery catheter neither increase overall mortality or days in hospital, nor it confer the benefit. So they did not actually found the much benefit or much complications related to PA catheter. And despite of almost 20 years of multiple randomized controlled trials, the clear strategy leading to improved survival with PA catheter has not been devised. So there are multiple initial trials which show that there is a higher mortality when we use PA catheter in patients of shock. And with this background and this evidence, the use of catheter, PA catheter is declined in all the ICUs and theaters, even in Western world. And then people actually looking for some other non-invasive hemodynamic assessment tool, and PoCUS, that is point of care ultrasound, emerged as an important tool in this hypotensive patient. If you compare the advantages and disadvantages of echocardiography versus invasive monitoring like PA catheter, as we know, we all know that invasiveness is much less, or in echocardiography, only when we do a TE kind of thing, it is a minimal invasive, otherwise it is non-invasive technique. But PA catheter is almost invasive procedure, require a lot of skill. Portability is generally not with PA catheter. And PA catheter cannot be used in acute setting like we can use an ultrasound or echo. Though diagnostic value of both the modalities are quite good, monitoring capability is good, but the problem with 2D echo ultrasound is that it is user dependent. Operator has to be really well trained in using this technology. And only positive point that PA catheter is less user dependent, but requires some calibration of the PA catheter monitoring. So let us talk of the focus cardiac ultrasound. Focus cardiac ultrasound is not ultrasound which is or echo which is done by a cardiologist, which they do a detailed 2D echo in a patients of critical ill patients. So it is performed by emergency physician or intensive at bedside. So it's an initial screening kind of a cardiac ultrasound. It is essentially limited to evaluation of cardiac function, pericardial space, intravascular volume. So it's very limited objective behind this focus. And even portable or even small pocket size handheld ultrasound machines can provide a good image quality for assessment of left ventricular function, for detection of pericardial effusion, and measurement of abdominal aorta size. So even small machines, portable machines are good enough to have initial screening and important information which we wanted from a hypotensive patient. And 2D and M mode are employed to assess focused cardiac ultrasound. So when we actually deal with a patient who is having hypotension and a shock, we actually need to answer a few important questions at bedside. Whether there is significant pericardial effusion present or not, whether patient's left ventricular ejection fraction is severely impaired or not, is right ventricle is significantly dilated, whether size of IVC, whether it is collapsibility is with inspiration expiration is more than 50% or not, and what is the pattern of ultrasonography artifact in the lungs. So lung is actually become a very important organ which can be screened by USG at bedside, and whether there is a significant valvular rigor present in mitral or aortic valve to diagnose endocarditis. So these are the basic. If we get this information by a well-trained emergency physician, anesthesiologist, or intensivist, we can actually categorize the shock in a better way for further management. So focus has emerged as one of the powerful tool for clinicians to answer simple clinical questions and guide subsequent management in a hypotensive patient. What are the limitations of this USG and echo is that difficult to obtain the images in a suboptimal sonographic window. The ICU patients are sometimes very difficult to have good windows. The hyperinflation of lung, bowel gases, obesity, patients on ventilator, there's a positioning problems. So they may render the image difficulty, and operator dependency is another limitation of this modality. So there are multiple protocols of point of care ultrasounds are recommended for undifferentiated shock or in a patient of even cardiac arrest. And cardiac arrest is another area where ultrasound and echo is emerging as one of the very important tool. So if you see the list of protocols right from 2001 to 2016, almost 16 to 18 protocols has been proposed. And what this protocol actually looked at, there's cardiac views, IVC size, abdominal aorta, and lung scan. And on basis of these few things, they actually look at the diagnosis of shock and etiology, and they monitor the shock. So these are the cardiac views which they use in these different protocols. So I'm not going to go into details of the, just wanted to highlight that there are multiple protocols are available. But importantly, we'll look at what is the FATE, that is a focus assessment in a trauma patients, then RUSH protocol, and the simple protocol. There are the few important protocol which we need to understand. Simple is an approach to evaluate the patients of shock, and simple, all words in the simple stand for some specific examination. So S stand for chamber size and shape, particularly LV and right ventricular size. I stand for IVC size and collapsibility, intravascular septum movement, intimal flap inside the aorta, which is actually suggestive of aortic dissection. So I stand for these three I's. M stand for mass in the heart, commonly intramural clots or atrial myxoma, or myocardial motion. That is, if patient is having motion abnormality, we are actually dealing with a acute myocardial infarction kind of condition. Then P stands for pericardial effusion, pleural effusion, L for left ventricular systolic function, and E stands for abdomen aorta in the epigastrium. So if you look at the epigastrium, you can look at the abdomen aorta and you can diagnose aortic dissection or aneurysm. So this is the simple protocol or have a diagnosis of shock patient. So your focus reveals hypovolemia. If you look at IVC and it is collapsible, and so there is a history of trauma or it's been suspicion of blood loss, you can add FATE as a focus assessment sonography trauma patient protocol, and combination of these two will actually look at intravenous bleeding or hemothorax for better management. So you can combine these two protocols in a patient of hemorrhagic shock. They are the common standard views in a simple approach. Is a pericardial long axis, external long axis, parasternal short axis, xiphoid four chamber, apical two chamber, and apical four chambers view. This xiphoid or epigastric views for inferior vena cava and abdominal aorta. You can see, you can look at aorta and IVC in a xiphoid view. So if you look at the summary of typical findings at different types and causes of shock by simple approach, if you just wanted to diagnose hypovolemic shock, your chamber size of LV is small, IVC is collapse, then probably you sometimes may get aneurysm of abdominal aorta and which is ruptured. So if these are present, you can actually diagnose a cause of shock. Even if patient's heart is actually dilated, not this IVC is not collapsible, less than 50%, IVS movement has reduced, myocardial hypokinetic, you can diagnose cardiac shock. So depending on this all SIMPLE, you can actually diagnose whether we are dealing with hypovolemic, cardiogenic, septic, or distributed cardiac shock, and you can diagnose pulmonary embolism, cardiac tamponade, and even aortic dissection with this simple approach. Another important protocol which I wanted to highlight is the RUSH protocol. It is a three-step protocol where we look at the heart, that is a pump, then tank, which includes IVC, interjugular vein, lungs, pleural cavity, and peritoneal cavity. And step 3 is looking at the pipes, that is aorta, femoral veins, and even popliteal veins for venous thrombosis. So this RUSH protocol looked at a pump, that is hypercontractile or hypocontractile heart, tank, which we look at IVC, and pipes we look at aneurysm or a DVT kind of thing. And we can categorize the shock in hypovolemic, cardiogenic, obstructive, or distributive shock. So this RUSH protocol has been actually studied in one of the paper published in Trauma Journal in 2015. And this, I found a very interesting kind of analysis. The objective of this study is to evaluate reliability of RUSH protocol to accurately diagnose the type of shock in some emergency patients, and to compare what they did. They compare the agreement index between the emergency physician who has done ultrasound at casualty immediately and followed by radiologists what they diagnose afterwards. So actually they looked at whether emergency physician is also able to diagnose type of shock with this rapid ultrasound in the shock patients. So we look at it, they categorize the patient based on the RUSH protocol, and the final diagnosis done by a very experienced radiologist. And they categorize patient in a hypovolemic, cardiogenic, obstructive, distributive shock or mixed shock. And some patient they could not diagnose, they defined as a non-defined shock. And if you see, if you go in each type of shock, the sensitivity of this modality is very good in hypovolemic, cardiogenic, and obstructive shock, slightly low in distributive shock and mixed shock, but otherwise sensitivity is very good. If you look at the specificity, is almost 90 to 100%, and the positive predictive value also is very good, almost 90% to 100% in different kind of shock, and even negative predictive value is almost 90 to 100%. So that is a really a very sensitive and specific method to diagnose shock in the emergency department. This study demonstrated acceptable general alignment between the results of early ultrasonography study and final clinical diagnosis patient of shock. And the study did not find any significant difference between agreement indices of exam performed by emergency physician compared to those done by radiologists. This is very important. We actually, a lot of people scared to do an ultrasound and echo, that we actually don't understand how to diagnose a lot of things on ultrasound and echo. But if you get a proper training, you can actually master this technique. And if you see, the emergency physicians who are not very trained can have also better diagnostic ability in a shock patient. This is another trial published in Critical Care Medicine, though it is a very old trial. I thought it is good to discuss in this audience. It is a randomized controlled trial of immediate versus delayed goal-directed ultrasound to identify the cause of non-traumatic hypotension in the emergency department. So they actually had a goal-directed management immediately and delayed management of ultrasound echo in hypotensive patient. So this was the randomized controlled trial of immediate versus delayed ultrasound. And what they did that they divided patient in two groups. Group one is immediate ultrasound, so at time of 0. And group 2, actually, they did ultrasound after 15 and 30 minutes after the initial ultrasound of time 0. And interestingly, the conclusion of this study is that incorporation of goal-directed ultrasound protocol in evaluation of non-traumatic, symptomatic, undifferentiated hypotensive patients, fewer variable diagnostic etiologies, and more accurate physician impression for failure diagnosis. So initially, you are actually not sure whether we are dealing with a cardiac shock or septic shock or something else. But when you do a immediate and delayed goal-directed ultrasound, your diagnostic options are actually shortens and you have more accurate diagnosis with the help of this ultrasound. Then which parameter actually help us in diagnosing shock? This is studied in one of the papers, that is evaluation of parameter used in echocardiography and ultrasound protocol for diagnosis of shock etiology in emergency. The aim of this study is to investigate which echocardiography and ultrasound parameter really help to differentiate various types of shock. If you see, the result of this study is that velocity time integral of aorta and IVC maximum diameter were very good in discriminating distributive shock as compared to left ventricular systolic function, presence of pneumothorax, pneumonia, wall vegetations were of great value in differentiating types of shock. So if you are dealing with vegetations on the wall, you are very clear that we are dealing with septic shock. But at the same time, that is compression use ultrasound, fast, TAPSE, RV diameter, were not very useful in differentiating shock. So this study actually said that, so conclusion, ultrasound and echography powerful tools that can be used to identify shock etiology when clinical picture is actually overlapping. Then this is another paper, the Journal of Clinical Medicine. They reviewed the ultrasound in sepsis and septic shock from diagnosis to treatment. So the state-of-art role of ultrasound in diagnosis in shock is been evaluated. The medical literature from last 20 years following electronic database from Medline, PubMed, PoCUS and Embase was evaluated. And the use of ultrasound throughout the process of diagnosis and treatment of sepsis and septic shock provides clinician with an adjuvant tool to better categorize the patient and ensure early aggressive as well as individualized therapy in a shock patient. So this clearly said that now we require an individualized approach for management of shock. And if you use ultrasound at bedside, it's a good adjuvant tool for categorizing the patient of shock and ensure early aggressive treatment. Then this is a systematic review and meta-analysis of RUSH protocol. This is a pooled estimate of data showed that RUSH protocol exhibits high sensitivity and specificity. And the conclusion of this meta-analysis is that RUSH protocol has generally good role to distinguish the state of shock in patient with undifferentiated shock referred to the emergency department. What is the diagnostic accuracy of point-of-care ultrasound in shock patient? This is again a systematic review with meta-analysis published in Critical Care 2023. Almost 1,500 patients studied in 36 studies and 12 studies with 1,100 patients were included in this meta-analysis. What they conclude that identification of etiology of each type of shock using PoCUS was characterized by high sensitivity and positive likelihood ratios, especially in obstetric shock. So again, multiple evidence showed that this modality is quite sensitive and specific in diagnosing etiology of shock. Then echocardiography shock management. So now it is again recommended that comprehensive in basic critical care echography is now regarded as a mandatory part of critical care. And I actually extrapolate that not only critical care, all anesthesiologists actually need to undergo this training. And there are clear guidelines available for how we can actually diagnose patients of shock. The majority of pathologies found in shock patients are really readily identified using basic 2D level and embodied echocardiography. So we don't have to master very detailed USG ultrasound to diagnose bedside shock. So with this background of 2D ultrasound as a modality and very strong evidence in favor of this tool, what I can tell you at the end of my lecture that echocardiography, perhaps the most single useful tool in diagnosis and management of shock, particularly where etiology is undifferentiated and multifactorial. I often see patients in ICU, residents and doctors, consultants are actually not very sure what we're dealing with, whether this is a which kind of shock it is. And actually, that is a really crux in management of patients of shock. Echocardiography in shock not only useful in diagnosis and management, it is also useful in monitoring the progress of the patient. So you can repeatedly do echocardiography and see whether your patient is improving or not. It is a non-invasive, rapid to initiate, and can be applied at bedside at any time, during daytime or night time. Initial basic or race study can lead to commencement of treatment with more advanced study subsequently provide incremental and vital additional information. So we actually have more studies to have accurate diagnosis. So it is recommended as a modality of first choice in a lot of consensus guidelines. Remember, no other investigative bedside tool can offer similar diagnostic capability, allowing for exact targeting the underlying cardiac and hemodynamic problem, whether it is a problem with the right heart, left heart, it is a problem with the fluids, pericardial or cardiac response to vasoplegia as in septic shock patients. So it's a really invaluable tool. The clinician needs to undertake a careful, structured echocardiography examination, even in the emergency situation where urgency demands the assessment, rapid assessment. So at last, the ultrasound and echocardiography is a very sensitive and specific tool, can be used at bedside. It can be repeated n number of times at the patient. It is a very cost effective, easily mastered. It is non-invasive, and there is strong evidence to use this technology in a hypotensive and shock patient. Thank you.